Hi, my name is Laura Avellaneda Cruz. I'm a licensed master social worker at the Alaska Native Tribal Health Consortium. I've worked here since 2010 on domestic and sexual violence projects, adverse childhood experiences, and maternal child health. I also have a background as a victim advocate and as a classroom teacher and a researcher. This is a training in 3 parts on the patient safety card approach to domestic and sexual violence education, screening, and response in healthcare. I want to share that many of the materials and the photos without attribution come from Futures Without Violence and the Alaska Family Violence Prevention Project. This is also a collaboration with a number of different project partners, and I will let them introduce themselves.
Hi, my name's Quenna Saffron. I'm originally from Nome, Alaska. I live here in Anchorage. I work at A&MC in surgical services as a circulating nurse. I do have a background in public health and biological sciences research.
I'm Mara Gotchik. I'm a pediatrician at Alaska Native Medical Center in inpatient pediatrics, where I've worked since 2011. And I'm also the specialty clinic pediatrician for Kotzebue, going up there 4 times a year to see kids in outpatient clinic.
My name is Jacqueline Richards. I'm from Cayena, Alaska. I'm a community outreach specialist for the Alaska Native Tribal Health Consortium. Part of my background involves working with people experiencing developmental disabilities. I was a direct service professional.
Hello, my name is Ariel Herman. I'm the training project coordinator for the Alaska Network on Domestic Violence and Sexual Assault. I've been working in the field of advocacy for almost 6 years in both rural and urban Alaska.
My name is Dan Hartman. I'm a physician with a background in public health. I've worked in 2 areas in Alaska, one in Western Alaska in Bethel for a fair period of time, and also now in Anchorage.
Hi, my name is Heather Palmer. I'm a certified nurse midwife and an employee of South Central Foundation. My background also is working in Peru, in Cusco, doing volunteer work in a birthing center where a lot of native Quechua women from the high Andes would come and deliver.
Waka. My name is Elsie Boudreau. I am Yupik. My Yupik name is Aburin, after my maternal grandmother. I am a social worker stationed at a program under South Central Foundation, but stationed at Alaska Cares, which is a program under Providence, and I work within the Alaska Native unit at Alaska Cares. And I work with children that have been seriously physically abused and sexually abused. I myself am a survivor, and I have a master's degree in social work, so I come from this both as a professional and with a personal lens.
Hi, I'm Linda Chamberlain, and I'm the founding director of the Alaska Family Violence Prevention Project with the state of Alaska in chronic disease prevention and health promotion. I'm an epidemiologist who's been working in the field of domestic violence for more than 2 decades now, initially specializing in injuries and the health effects on women, and then as we began to understand more, particularly around early brain development and toxic stress, we started focusing on the effects of domestic violence on children.
The objective of the first training is that you will be able to describe domestic and sexual violence and reproductive coercion and its effects on health and healthcare utilization. Now, I want to make clear that this training addresses domestic and sexual violence against adolescents and adults. It does not address all forms of child maltreatment. It does address children's exposure to domestic violence and the relationship between that and other forms of child maltreatment, but this isn't a training on how to identify or respond to child abuse specifically. There are wonderful trainings available for that, and I would recommend contacting the Alaska Children's Alliance or Alaska Cares to ask about training opportunities on that subject. The objective of the second part of the training is that you'll be able to create a safe environment where patients can discuss domestic and sexual violence. The objective of the third part of the training is that you'll be able to respond with support, risk reduction, and resources to your patients who are experiencing domestic or sexual violence or reproductive coercion. I also want to acknowledge that talking about these subjects and doing this work can be hard, so take care of yourself during these trainings. Take breaks as often as you need to. You can pause this video, and if you have any questions or concerns about domestic or sexual violence, if this brings things up for you, below are the numbers for 2 national hotlines, and then the last resource on the slide are where you can get Alaska specific resources for domestic and sexual violence. And I want to share with you this quote from Mr. Rogers. He said, "When I was a boy and I would see scary things in the news, my mother would say to me, 'Look for the helpers. You will always find people who are helping.' And I share that because you are the helpers. You are the people at the front lines helping. And you're doing really important work. But it can be hard."
So just in the work that we do in working with survivors and oftentimes hearing their stories, and maybe for some of us seeing the injury, that it is going to affect us, and we take it in no matter how, in whatever way we deal with it, we do take it in, and we have to find a way to be able to take care of ourselves so that we don't get to a point where we are burnt out or feel like our heart is callous. So we want to come always from a place of caring, especially with survivors, because they need that validation. And so when you get to that place of feeling like you just need a break, it's okay. It's important to find ways to take care of yourself and to know that you're not working in this alone, that there are teams of people and resources available for you. And it's okay to cry. It's okay to do whatever you need to do to take care of yourself. And oftentimes it's helpful. I know for me, oftentimes what I'll do at the end of my day is I'll make a conscious effort to go into the restroom, and I just wash my hands and I just say, okay, I'm leaving this here, right? And so it's a way for me just to leave it at work, so that I can come back, and I can be at home, and then I can come back and be at work. So, and then just finding ways to talk to my coworkers and knowing that we're in this together, and I can say as a survivor, before I found my voice, I felt like I was all alone on an iceberg. And through coming forward and having talked about my own story and having people believe me, I know I'm not alone on that iceberg. And so it's almost like as providers, we're with people on that iceberg. And so oftentimes we need to find a way to step back and go and be on our own ground, and so that we are able to join people.
And one of the reasons why this work can be hard for healthcare providers and others is that it can often bring up things in our own life. Many healthcare providers have experienced domestic violence, might be experiencing it now, have experienced abuse in the past. And I want you to know that advocates, just as they are there for your patients, are also there for you. You can reach them 24/7, one of the national hotlines or one of the local hotlines, and they're there to answer questions, support you in this work as well as your patients. Throughout this presentation, I'll be sharing some thoughts on what this could mean for your facility in terms of updating policies or practices. And so one of the implications for your facility is that you want to make sure you have an employee assistance program that provides counseling and other types of support for you and other employees doing this work. You also want to have a domestic violence policy for your employees that is based on the best practices for how to support employees who are experiencing domestic violence and not penalize them for that experience. And you also want to find opportunities where your staff can provide peer support, and opportunities to debrief and talk about how this work is affecting them, ask questions about the work, how to best support trauma survivors, etc. We'll begin with the learning objective for the first part of the training, which is that you'll be able to describe domestic and sexual violence and reproductive coercion and its health effects, focusing first on what is domestic violence, sexual violence, and reproductive coercion. So when you hear the term domestic violence, what do you think of? Oftentimes people think of the obvious physical forms of domestic violence, the black eyes, the being pushed down the stairs, the broken bones, and that can certainly be part of domestic violence. But it's important to understand what it is and how it functions. This definition is a more comprehensive definition. What's important about this definition is that it's about a pattern of coercive and controlling behaviors that a partner is choosing to use against someone to maintain power and control. So it's not just that they need some anger management help. It's not just that they got really frustrated. It's about maintaining power and control. The techniques that an abuser might use to maintain power control are actually very diverse. These can include physical violence, which of course includes hitting, pushing, slapping, also very severe forms like choking and strangulation or use of weapons. It almost always includes emotional or psychological aggression, so threatening, humiliating, degrading someone, calling them names, controlling and isolating. And this is really important because controlling behaviors, keeping a victim isolated and controlled away from their support networks, away from the family and friends who would care about them, that's what makes it so hard for someone to exit an abusive relationship. The farther they are taken away from their support networks, the harder it is for them to understand and be able to access their options to leave. Other coercive tactics are part of emotional and psychological aggression, including stalking, tracking somebody's every movement, etc. Sexual violence is something that is often not talked about or thought of in the context of domestic violence, but is really important. It occurs in a lot of abusive relationships, and it also is a form of violence that can occur outside of a relationship, a romantic relationship or an intimate partner relationship. This can include forcible sexual assault, but also coerced sex and sexual humiliation. So somebody may want to have sex with a partner, but may not want to do it in a painful or degrading or humiliating way. And so part of that violence or that control might be about forcing them to have sex in those ways, or forcing them to do drugs and have sex with other people in front of them, or sex trafficking or commercial sexual exploitation, which is where someone has to engage in sexual behavior in order to get something of value or something that they need to survive. And it also can include control of reproductive or sexual health. I want to share in a little bit more depth about sexual violence because many of our patients, many people in general, don't necessarily know what's included in sexual violence or know what the rights are. So the definition I like to share is that sexual violence is any kind of sexual contact without consent, and that any kind of contact meaning from unwanted kissing or groping to penetration. The key part here is that it happens without consent. So what does consent mean? Consent is an emphatic, an enthusiastic, not a pressured or guilt-tripped yes, but an emphatic yes. It's clear. It's not just something that someone reads in someone else's body language as a yes, but it is very clear and verbal agreement by all parties to engage in a specific activity. I say specific because consenting to kiss is not necessarily consenting to do more. Consenting to be naked isn't even consenting to have sex. Or consenting to one type of sex is not consenting to another type of sex. The agreement needs to be present throughout sexual activity. And so somebody can start to have sex and then change their mind, and their partner needs to respect that. Consent also requires that partners are able to consent. To be able to consent, they need to be of equal power. So what are some examples you can think of partners who are not of equal power? Yeah, so you probably thought of children with adults, or children with teenagers, or teenagers with adults. You might have also thought of teachers with students, prisoners with prison guards, bosses and employees. Other times when there is a clear imbalance of power, so that even if that person says yes enthusiastically, there's still an element of coercion because of that power imbalance. Partners also need to be of clear mind, meaning that not intoxicated, not passed out, not asleep, etc.
If you want more information for yourself or someone else about consent, or if you're not sure you understand or agree completely with this definition of consent that I shared, here are some fun, engaging, easy to understand videos and other resources on consent and preventing sexual violence.
Let's talk about reproductive coercion. Reproductive coercion is any coercion around reproductive health. So this may include explicit attempts to impregnate a partner against her wishes, controlling the outcomes of a pregnancy, which can mean forcing someone to terminate a pregnancy, or getting someone pregnant and then not allowing them to terminate that pregnancy, threatening to hurt them if they do. It can include coercing a partner to have unprotected sex, or refusing to use condoms, threatening them if they try to negotiate condom use, and actively interfering with birth control methods. This can include throwing away birth control pills, hiding birth control packs, replacing them with something, not allowing someone to return to the clinic for their depot shot, even pulling out IUDs. It can also include poking holes in condoms, taking condoms off during intercourse, and so on. I want to share with you a quote from a 17-year-old in a research study who's experiencing multiple forms of reproductive coercion, and I'll let you read the quote. So as you can see, this young woman's partner was tampering with her birth control methods of condoms, and then when she did get on a better birth control method, was pressuring her to become pregnant. How common is reproductive coercion like this young woman is experiencing? Well, there are a number of studies looking at this, and in this one, the National Domestic Violence Hotline Survey, they asked questions about reproductive coercion to over 3,000 callers to the Domestic Violence Hotline, and they found that 25% of those callers had answered yes to at least one of the following 3 questions, and I'll let you read those. So that study was a reproductive coercion experienced by people who were calling domestic violence hotlines. So many of them had or were experiencing domestic violence. What part of the population might that represent? Well, one source of data that we have is the 2011 statewide Alaska Victimization Survey, and that survey found that 59% of Alaskan women have experienced either physical intimate partner violence, sexual violence, or both in their lifetime. And 12% experienced one or both of those forms of violence in the past year. Now that survey did not include males, and so the CDC's National Intimate Partner and Sexual Violence Survey, which uses very similar questions to the Alaska Victimization Survey, found that bringing together multiple forms of victimization, more than 1 in 3 women and more than 1 in 4 men had experienced rape, physical violence, and or stalking by an intimate partner in their lifetime. Looking at the Youth Risk Behavior Survey, which is a survey done by students, a paper and pen survey done by students in high schools in Alaska, 9.1% of teens in Alaska in traditional high schools report that they've experienced physical dating violence in the past 12 months alone. And in that same survey, 11.4% of teens in traditional high schools reported that they experienced sexual dating violence in the last 12 months. So this is a very significant proportion of our youth in Alaska. And those numbers are even higher for youth attending alternative schools. In 2013, for the first time, we asked adverse childhood experiences questions in the Behavioral Risk Factor Surveillance Survey, which is a telephone survey of over 2,000 Alaskan adults. These are questions about things that happened to them before they were age 18. And what we see is that 23.1% of Alaskan women and 7.2% of Alaskan men experienced sexual abuse by someone 5 years or more older than them when they were young. So we know that this is a very significant problem for Alaska. So who is affected by abuse? As we saw from the Alaska Victimization Survey, a majority of Alaskan women. Abuse can happen to people of any racial, ethnic, class, religious, or national background. It can happen to people of any gender, any sexual orientation. Abuse doesn't really know any boundaries at all. This is a problem that is a global problem and all of us face and need to tackle together. However, sometimes providers will notice that there might be patterns, there might be certain people who seem to be more vulnerable to abuse than others, or there might be disparities in victimization. So what puts some people at greater risk than others? I'm going to share with you some brief information from the CDC, and what they did is they put together all these different forms of violence and looked at risk factors in common between different forms of violence. And what they found is that there are risk factors at the societal level, at the community or neighborhood level, at the family level, and at the individual level. And these are just some of them that have been found in research. There are also protective factors at these levels, things that, if they're present, people are less likely to perpetrate or be victimized by abuse. And I share these with you just to say that This isn't about a person's individual failing. This is not about a particular person just being flawed. This is about societal, community, family, and life circumstances that make some people more vulnerable than others. And so we just want to treat people with compassion and understanding for what has brought them to this point in life, not use judgment against them.
So in my work with the Child Advocacy Center, we see a lot of children. We see about 900 children a year. And of those children, about 38 to 43% are Alaska Native. And many people have asked, why is it that so many Alaska Native children are sexually abused? Why is it so disproportionate? And it's almost like you can take that and you can take it and apply it to domestic violence and alcoholism. You know, why is it that so many Alaska Natives are disproportionately represented in all those social ills? And I remember working with one survivor who had been sexually abused by a clergyman, and he had gotten in trouble with the law many times and had a history of alcoholism. And he had told his wife about having been victimized as a child, and his wife told his mom. And what his mom said is, "No wonder." It made sense to her. And it's almost like we can apply that same statement, "no wonder," to the historical trauma that the Alaska Native people have been through. We can say, if we understand the historical trauma, the Great Death era, the boarding school era, and not just understand it and know that it's out there, but know stories. We're talking about our people whose hearts were broken, whose lives were shattered and changed forever, who are raising children. And so if we can put on a lens of understanding with that same term, "no wonder," when it comes to historical trauma, and connecting that to why things are the way they are today, I think we'd have a broader understanding. And so I would encourage people, you know, if you don't know, ask. It's okay to ask questions, to open up the dialogue. So I think it's new that we have this term now, intergenerational trauma or historical trauma, whereas during the time of the Great Death, that was not a term, right? And and we know now how that affects our brain and the development of the brain. And so there's so much, you know, there's so much we can connect. So just being mindful of that and being aware.
So as Elsie explained, there is so much in our history and in our current systems of inequality that can contribute to these disparities in victimization. And so I just want to leave you with a few links. You can pause your video and copy these links, or they will also be included in the resource page at the end of the training. Now, many times as providers, you may see patients who have experienced sexual assault, and not all of them want to report those assaults. And if they're an adult, that is their choice whether they want to report it or not. So let's think about some reasons why someone may not want to report a sexual assault. They may be afraid of repercussions or retaliation from the perpetrator or the perpetrator's family. They may feel shame about what happened, and they may even blame themselves. They may not identify what happened to them as sexual assault in some cases, because as we spoke about earlier, not everybody knows what their rights are to their body. They may not trust that the system will work, and that may be because they've seen that the system has not worked well for other victims who have gone forward and reported. They may still be connected to the perpetrator in a way that would make them afraid to initiate that legal process. And the authorities might be related to the perpetrator, so it may be that the person they're reporting to in their community is related to the perpetrator. I share these with you just so that we can meet people where they're at and without judgment. Reporting might be the best choice for someone to make, or it might not be, and that's their choice to make if they're an adult. And it is a choice that an advocate can help them make, help them understand what might happen in the reporting process. Let's think also about reasons why a domestic violence victim may not want to leave or be ready to leave an abusive relationship. Some reasons might be that they want the abuse to stop but still love the person, and they may think that it's possible for that abuse to stop within the relationship. There are a lot of cultural messages that reinforce that belief. The process of change can often be slow and takes an average of 7 times leaving before somebody is able to fully leave those relationships. And so we want to be patient and supportive through that process of change. Economics are a major factor. Someone who, especially if somebody has not been able to work, they may not have the resources to live on their own. They may be afraid of what will happen if they lose the income of the abuser or lose the hunting ability of the abuser to provide meat for their family. Housing is a major issue. If there is often a lack of affordable housing or housing at all, there might be immigration concerns, particularly if an abuser has kept the paperwork of the victim and not allowed them to continue the process of paperwork, has hidden their green card or their passport, etc. There also may be language barriers, particularly with immigrant victims or Alaska Native Elder victims. The victim may be afraid that the abuser will take custody of the children, and that's often a threat that's used by abusers, is that they will take custody of children if the victim leaves. They may fear that the disapproval or retaliation from their community, including their family. Most important for you to remember is that leaving or ending in a relationship is the most dangerous time for a victim. It's the point at which they're most likely to be killed. So if somebody is ready to leave, we want to make sure that they're doing that with the support of a victim advocate to help safety plan around that. We don't want to just urge people to leave and put them at that risk. We want to connect them with the resources to do that safely if they're ready to. And so Ariel Herman will explain a little bit more about what advocates do.
I'm here to talk to you a little bit about what the role of the advocate is and how you can utilize an advocate in your medical practice. An advocate is someone who works usually at a domestic violence sexual assault agency. We have both DVSA agencies all over the state as well as some tribally affiliated ones. The role of the advocate is really there to support the victim or survivor in the process of what they're going through. The perspective that we come from is very much about empowerment. That being because victims and survivors are coming out of a relationship that's been very based on power and control of one person over them. And so when they come to work with us, we try to help them find that power and control back in their lives. And so we don't want to make decisions for them, but rather present options where they can then decide for themselves what's safest for themselves. Another reason for that is because they know their lives the best and will be living the consequences of what they choose. And so as advocates, we can help present options and help them figure out what makes the most sense for them in their situation. So a lot of what we help them do is safety plan. So depending on whether they want to stay in that relationship or leave, we help them figure out the safest way to do either of those situations. That may mean helping them get referred to other resources, getting connected to different systems, potentially even going with them to navigate those systems. In Alaska, we have several domestic violence and sexual assault agencies across the state. We have almost around 20 programs in most of our hub communities. These agencies are there to support victims in whatever ways that they can. So almost all of our programs have 24/7 crisis lines. Many of them have toll-free numbers, so people outside the community can also call easily. We also have shelter programs, and these are programs generally for women and their children. We also have ways to support men in being in safe places as well, even if they aren't able to stay directly in our shelters. Ways that healthcare providers could work with advocates. One of the number one ways is to give a referral, and many ways to do this. You can just give out the information, but another option is to see if the patient would like to call the program, and you could do that with them, or you can just offer a safe space in your clinic for them to do that, for them to be able to hook up with an advocate to do more safety planning. And that's one of the main things that distinguishes us from behavioral health providers, which we can work very well in teams with. We are more on doing things like safety planning and helping them figure out the different systems and processes that they need to keep themselves and their children safe in their lives. And so we may, as advocates, then refer them over to behavioral health to help them focus on the counseling aspects of what they're going through. And the other difference is that we're able to provide a different level of confidentiality, so our records are generally not subpoenaed, whereas that might be a different system for behavioral health providers. So back to medical providers and working with advocates, referrals is number one, and those referrals can be for the crisis line, for shelter, for having an advocate come down to the clinic to meet with them in person if you have an advocate in your community, safety planning, legal advocacy, including obtaining protective orders and court accompaniment, and support groups. So referrals is a major way that advocates and medical providers can work together.
Family advocates are another kind of advocate, and they help when there's child abuse. Elsie Boudreau will explain their role.
I am a family advocate, and I'm stationed within Alaska Cares, but there are other family advocates at child advocacy centers throughout the state. And basically what our role is to act as a bridge between the family and the multidisciplinary team. And we are a support for the family in their process as they go through the child advocacy system.
For information on advocates in your region of Alaska, please visit the 2 links below. One goes to our Epicenter Healthy Families page, which includes region by region resource guides for all domestic and sexual violence services that you can download. Also, Alaska Network on Domestic Violence and Sexual Assault's webpage has a directory for every domestic violence provider in the state. So now we're going to focus on the second part of the first objective, which is the effects of domestic and sexual violence on health and healthcare. We'll go through the life cycle to talk about this, beginning with pregnancy. So some of the ways that moms and babies are affected by abuse during pregnancy are an increased risk of miscarriage, of pregnancy complications, including antenatal hospitalizations and severe vomiting and diarrhea, an increased risk of uterine rupture, and poor birth outcomes that can include low birth weight and very low birth weight babies and preterm births. And of course, those put that baby at risk for lifelong health problems. And then abuse can also cause epigenetic changes in that developing child. What that means is that we get our genes from our parents, and they're pretty set. But a lot of the way we turn out actually has to do with epigenetic changes, which are epi means on or upon, so it's changes that can occur onto the genes because of environment. And so what these changes can determine is whether a gene expresses itself or not. And the early uterine environment has a big determination in which genes express themselves. For example, babies who are in a really stressful uterine environment tend to have a very reactive glucocorticoid receptor, which is a gene that determines their stress response. And so the uterine environment that they're experiencing is full of stress, full of cortisol, and so the gene is preparing itself for a stressful, dangerous world by having a really, really turned on stress response. Whereas a baby who's in a more safe uterine environment doesn't need to turn that gene on in the same way. In fact, a recent study by geneticist Joan Kaufman in 2013, where she looked at 96 children of substantiated maltreatment with 96 children of similar backgrounds without maltreatment, what she found is that there were changes to over 2,000 genes in the children who had been maltreated. And these were genes that predisposed them to obesity, to a number of different psychiatric problems such as depression and anxiety, and also genes that predispose them to heart disease, cancer, diabetes, and more. And so these epigenetic changes can have a very significant effect on children. However, as we'll talk about later, there are many things we can do to help children to heal, so not all of these changes are permanent. And for more information, because this is a huge topic that we don't have time to get into in great depth here, I recommend this link, and you can pause your video and copy this link, for the University of Utah Genetic Science Learning Lab. It's very easy to understand and very interactive. So we talked about some of the direct effects of abuse during pregnancy, but there are also some indirect effects. If a woman is being abused during pregnancy, she may also be more likely to use unhealthy coping mechanisms such as tobacco or alcohol. Another reason for that might be that the substance abuse is part of the abuse, and so the perpetrator sometimes tries to keep the victim using substances.
So women who are physically abused during pregnancy are 7.8 times more likely to drink while pregnant. And we've known this for a while because if you're familiar with the Pregnancy Risk Assessment Monitoring Surveillance called PRAMS in Alaska, every month hundreds of women are getting a survey after giving birth and giving information about their experiences around the time of pregnancy. And one of the things that we saw early on in that Alaska data, and this is all women in Alaska who have had a baby, are eligible to be in the survey, we could see the connection between drinking during pregnancy and being a victim of physical domestic violence.
We all want to prevent fetal alcohol spectrum disorder, but if we want to do that, we need to attend to the role of domestic violence in substance abuse during pregnancy. Women who experience domestic violence during pregnancy are also less likely to initiate breastfeeding and more likely to cease breastfeeding by 4 weeks. And we know that breastfeeding is so protective for babies and moms, both against infections and illnesses, but also chronic diseases long term. And international studies in multiple countries across the world have shown that breastfeeding decreases the likelihood of abuse and neglect. And so breastfeeding is so protective, but women who are being abused might choose not to breastfeed because baby's in the zone of danger.
I got a phone call years ago when we first started the project from Providence Hospital, and they asked me to come over and talk about breastfeeding and domestic violence. And at the time I was like, well, I don't know much about that. Can't you call those La Leche Lychee people or something? And they said, I guess you don't understand. And we didn't at that point. Even though they weren't routinely screening for domestic violence, which they do now with all women who are delivering babies, they would ask if a woman chose not to breastfeed, what the reason was. And without doing direct screening for domestic violence, the leading reason being given was domestic violence in their relationship. Now, I, as an injury epidemiologist, was aware that the pattern of injuries during pregnancy actually changes, and we see a lot of focus in terms of the battering around the abdomen, the genitalia, and the breast. In other words, mom realizes that she's holding the baby in the zone of danger. And when I think back to clinical training decades ago, when I was in hospitals, and the ripped episiotomies and other injuries that we saw, and we didn't connect the dots. But now we know. And since that question was asked so many years ago, and we started having conversations, because I called my colleagues, and eventually we would be doing research with that PRAMS data that I mentioned earlier, and other studies showing a clear connection in terms of women choosing not to breastfeed or ceasing to breastfeed because of the violence in their relationship. If you're screening for postpartum depression, you need to be screening for domestic violence, because women who have violence in their relationship are 5 times more likely to experience postpartum depression. We also see issues around maternal attachment, which is huge when we think about early brain development. That bonding and attachment that needs to happen to stimulate a baby's brain. And there is a significant connection with infant mortality as well.
Moving into childhood, Dr. Linda Chamberlain will talk about the effects of domestic violence on children.
Family violence, domestic violence, is a package deal. We are looking more and more at the intersection between domestic violence and adverse childhood experiences, which we are talking a great deal about in Alaska. And when we look at the intersections between the different forms of family violence and things that we may not even be connecting, like what we call the toxic triad between domestic violence, child abuse, and animal abuse. When I'm working with communities, one of the first questions, if we're talking about a coordinated community response, is I want to know, is animal control here? Because they often know before we do what they're seeing in a household in terms of hurting pets in the household, demonstrating to the adult victim what's going to happen to them, what will happen to the children if they don't do exactly what that person wants. We also have studies back to the 1960s looking at the connection between sexual abuse and domestic violence, particularly incest. And so again, when we're doing programs, we're screening, thinking about sexual abuse prevention, we've got to be thinking about domestic violence prevention. If we see one, we need to have a high index of suspicion and concern for other forms. And I'll just mention to you too that early in my work, when I started going out to communities in Alaska and talking about domestic violence, a question that would frequently be asked of me, particularly by the elders, are you going to talk about elder abuse? And my first response was, well, that's another program in the department. We're the Domestic Violence Project. And that's when I got a reality check, because what you realize is that children who grew up in homes with domestic violence, when we didn't talk about this, when there weren't interventions and help out there in the community like there are today, you grow up with this, family violence becomes a norm. No one ever talked about it, and now they're the caregivers for who? Abusing parent, victimized parent, often both at the same time. And domestic violence, when we don't talk about it, when we don't do something about it, it's still there. It just comes out in other ways. So it's about seeing the big picture here of family violence. So we were talking about the connection between domestic violence and adverse childhood experiences. And this is a slide talking about that overlap. So substance abuse in the household, child abuse, child neglect, having a caregiver or another adult in the household with a mental illness, incarcerated parent, sexual abuse. These are some of many ACEs or adverse experiences that often co-occur when domestic violence is going on. And in fact, a child in a home with domestic violence is 95% likely to be exposed to another adversity. Again, it's about connecting these dots. When we look at a child that has been exposed to domestic violence, 1/3 of children in that situation are going to have 4 or more adversities. Childhood adversities are good buddies. Domestic violence hangs out with a lot of other tough times for kids in the same household.
You may have heard about the ACEs study and how it has shown us that adverse childhood experiences can have a lifelong impact on health, on physical and mental health. Well, how is that what happens in childhood from chronic stress can impact physical health so much? To talk about that, I'm going to wear this apron and brain to demonstrate how stress can affect the body and all of its systems. I'll tell a story to illustrate it. So last summer, I was on a hike with my baby strapped to my chest, my 5-month-old baby, and a bull moose came out of nowhere and started charging us, just came up the hill. So that was a stressor, right? The stressor was the moose. It immediately sent a signal to my brain without me having to think about it. So it bypassed my prefrontal cortex. I didn't need that. I just needed to survive. So my brain, through the HPA axis, the hypothalamic pituitary adrenal axis, sent out signals to my body and filled my body with cortisol and adrenaline so that I could be ready to respond. Our 3 response options are to fight, to freeze, or to flee. And so I choose to flee in the case of a moose. And what my body did in response, because of that cortisol and adrenaline, it told my body to increase my heart rate so it could get blood to my larger muscles so that I could get me and my baby up the hill behind a tree away from the moose. I also needed as much sugar in my blood as possible so that I could run. And so my liver had to start producing glucose, had to start turning glycogen into glucose and getting it into my blood. Had to increase the amount of cholesterol in my blood as well. My pancreas started churning out glucagon so that I could use that sugar more efficiently. Right? That also helped shut down my digestion. And I may have already eaten that night, but was digesting a priority when I was trying to get away from that moose? So my digestion shut down. I may have been exposed to a cold virus that day, but my immune system was not the priority right then. My priority was survival for me and my baby, so my immune system shut down. The good thing is we got away from the moose after a while, and my stress response got to turn off. My blood sugar got to go back to normal, my heart rate, my digestion, my immune system, everything got to turn back on because the stressor went away. It worked. It worked well. But what would happen if every single time we stepped out of the house, a bull moose was charging us, right? What happened if we were constantly being charged? That's what it's like for children who are experiencing chronic stress. Instead of a bull moose, it's walking on eggshells around the house because they never know what's going to set off the abusive person in the house. It's that person coming into their bedroom every night, right? If they have chronic stress that's not mediated by caregivers, then these systems don't get to return back to normal. So it's no wonder that kids who are having their digestion shut off so frequently have tummy troubles, have GI problems. It's no wonder that they get sick more often if their immune system is not able to function right. It's no wonder that they are more predisposed to obesity and diabetes, type 2 diabetes in childhood, right, if this blood sugar process is happening. And it's also no wonder that we see more attention deficit hyperactivity disorder and other learning disabilities in kids who are having to just stay in their survival brain in order to survive that chronic stress. So children who are exposed to domestic violence have a much higher likelihood of experiencing a number of chronic problems, including inflammatory problems like asthma and allergies, which makes sense given that chronic stress response.
Further confirming the link I mentioned earlier between chronic stress from things like domestic violence and childhood obesity, a study in 2015 found that domestic violence was a strong predictor or risk factor for obesity in Alaskan 3-year-olds, and for Alaska Native children, it was the strongest predictor for obesity.
Exposure to domestic violence affects access to health care, not only to prenatal visits and all kinds of health care issues in terms of moms, but also for kids being exposed to domestic violence. So we know that kids in homes with domestic violence are less likely to have the 5 well-child visits during their first year of life. They're less likely to be immunized before the age of 2, and they're way more likely to have ER visits for injuries and other health problems. Children exposed to domestic violence are at significantly higher risk for post-traumatic stress disorder, depression, anxiety disorders, developmental delays, and this is often misunderstood because a child will be doing all the things that they do in the cortex of their brain, learning how to potty train, put words together, bonding with their caregivers, and things start to get scary. They don't feel safe, and they have to go down into the survival area of their brain, and they can no longer work on those tasks. So developmentally, they leap back until they feel safe and nurtured again, and will go back to those tasks. We also see big issues in terms of aggressive behaviors, bonding issues. When we talk about how exposure to violence affects a baby's or a child's developing brain, it's really helpful to understand how stress in the brain works. So all children are exposed to stress, and not all stress is bad. We sometimes call it eustress or positive stress. It's a part of healthy development to learn how to deal with stress. So anything from a child's hungry and wanting to be fed to talking about what they did during the summer at kindergarten. These things are mildly stressful, but they are happening in the context of nurturing caregivers, and they are not prolonged, and it's not happening with a bunch of other bad stuff. We also know that there are stressors, tough times that any child is going to experience. It could be an illness for that child, or having to go to the hospital, a family illness, loss of a loved one, or separation from a loved one. But again, typically not prolonged, not happening with a lot of other difficult things, and most importantly of all, you have nurturing, caring parents, other caregivers who help that child how to learn to deal with stress. That is how children cope with stress. They learn their coping mechanisms, how to deal with it from us. The problem when we talk about exposure to domestic violence and other adverse childhood experiences is that they are often prolonged, they're happening, they're severe or high, and that they're very hard on a child's brain and affecting the wellness of their body and health. And when they can go toxic is when there isn't that support of parents and other caregivers to help that child be resilient in those experiences. And that's when we see changes to the brain and health effects. Excessive stress disrupts the architecture of a child's developing brain. A young brain is very vulnerable to stress, and it can lead to a much shorter wick or ability to deal with stress. This gets patterned in the brain in a way that the body responds very swiftly and starts sending out lots of cortisone in their system that becomes oversensitized to stress. This very famous brain scan, which I like to share because we often tend to overlook the effects of neglect. When we look on the right, that exposure, that toxic experience for that child in the absence of supportive caregivers was solely emotional neglect. When you look at a scan, a PET scan like this, what we want to see is lots of color. The more red, which is the highest level of brain activity, tells us that this is a busy brain. Yellow is a lesser level, and when we look to those circles in the temporal lobes, what we are seeing is not much activity or no activity at all. We're looking at the brain here from the top down. So at the top is our prefrontal cortex, again, our temporal lobes and such. And on the left, you see a healthy, normally developing brain given an appropriate task that is very busy making lots of brain connections. We go to the bottom of the scan, we're still going to see red and yellow. That's the survival area, brainstem area of the brain, and that's always going to be lit up because that's a part of the brain that keeps us alive. But you don't want to see a child spending most of their time putting connections in there. When we go over to the right, we see a much more active survival brain area, and when we go up into the temporal lobes, we see very little activity. This is the dilemma of spending too much time down in survival brain, because that's where stress can push a child, especially a child who's living with domestic violence. A challenge that we see is we know that domestic violence can be a potential barrier to positive, nurturing parenting. We know that perpetrators of domestic violence parent differently and often are more likely to use physical punishment, have inappropriate expectations of the children, and use the children to meet their needs. And we know that when a parent is being victimized, experiencing domestic violence, that they can be so stressed just in trying to keep everything okay that it interferes with their ability to be a nurturing parent. It can push them more towards using physical or corporal punishment, because if that abusive partner is saying, if you don't keep those kids quiet, if you don't do exactly what I do now, that causes parenting to be compromised. And that's why we really need to be thinking about trauma-informed parenting when there's domestic violence.
To support this goal of trauma-informed parenting and to support positive parenting in general, Linda's group, the Alaska Family Violence Prevention Project, has partnered with other organizations to bring the science to community in this series of books called the Amazing Brain Booklets.
So we have a series of 5 booklets now. They're written at the 5th grade reading level to talk about early brain development, to talk about trauma and the potential for healing. We also have a booklet about the amazing adolescent brain, because it is totally amazing. And we need to understand that when we've missed intervening with young kids, that adolescence is a time of great brain change, risk, and opportunity to reach kids. We have another booklet that's specifically on positive parenting, and our latest booklet on adverse childhood experiences, although it's not called that, it's apps for happy, healthy children, is really meeting parents where they're at relative to their life experiences, because they may have grown up in households and had experiences that affects how they parent now, and helping them to understand how to take care of themselves to be the kind of parent that they want to be, and also how these experiences can affect their children when we don't recognize how the subtle effects often of growing up with domestic violence and other adversities. When we develop resources, we're into free. So these are free resources that can be obtained in any quantity that you need, and they're sent to you for free.
So now we're going to talk about how domestic violence exposure affects teenagers.
One of the challenges with understanding the effects and the long-term effects of exposure to domestic violence is we may not recognize how these experiences can emerge later on during adolescence, when they are going through tremendous changes in terms of their body, their brain development, their relationships. And so people may not recognize, because they'll say, well, when things were really bad at home, child was fine. They didn't ever talk about it. They didn't act out. We thought things were fine. We didn't talk about it. But now they're hitting adolescence, and we're seeing all kinds of behavioral problems, self-medicating, and otherwise, and not recognizing even that the fact of drinking may not be about experimentation in adolescence, but rather just this kid trying to feel okay. A lot of effects of domestic violence, childhood exposure can emerge during adolescence.
So when teenagers are exposed to domestic violence, or when they were exposed to it in childhood, we see an increased risk for school failure and poor school performance, an increased risk of suicide and other behavioral health problems, of dating violence, and of pregnancy. And so let's focus a little bit more on pregnancy, thinking back about what we learned about reproductive coercion earlier. This study found that adolescent girls who were in physically abusive relationships were 6 times more likely to become pregnant than non-abused girls. And as we discussed earlier, reproductive coercion can be part of those abuse tactics, or just girls feeling unsafe to negotiate safer sex practices and condom use with their partners, as this study showed. Now, of course, what puts girls at risk for unwanted pregnancy is also puts them at risk for sexually transmitted infections. And this study found that nearly half, 47.8% of adolescent girls who were tested for STIs and HIV had experienced physical or sexual intimate partner violence. And that's a very significant number. But I don't want to leave you in this section on a bad note. So I just want to come back to the fact that research also shows us that well-timed interventions in a number of sectors can make a difference. They really can help children not only survive but thrive after exposure to trauma. And we are part of that. And this website, Promising Futures Without Violence, has a number of evidence-based practices that you can use with children and teenagers exposed to violence and with moms. These are practices that promote resilience and protective factors for kids. We can help. We can help prevent abuse in the first place, and we can help children to heal from it, even children who are exhibiting multiple risky behaviors and maybe some of our more challenging patients. What you do can make a difference for them.
Now Dr. Dan Hartman will share the first of 2 case studies. This case study brings together much of the information we've just learned about on how abuse might present in clinical settings, and this is about an adolescent patient.
So you're starting your day in clinic and you have a 15-year-old that you haven't met before. She's coming to you in follow-up from urgent care fast track. You do a quick chart review and see that she's really missed most of her well adolescent visits, but she has been seen 2 times recently in urgent care for STI screening, and on this last 3rd visit she was diagnosed with pelvic inflammatory disease. Chart review also shows that she has a history of a fracture of her humerus at age 5 and well-controlled eczema. She's got normal growth and development, and the exam is normal. Review of her labs is really benign, but shows that she does have chlamydia infection, which you expected. She is responding appropriately to treatment. She's vague regarding the age of her partner, and social history is notable for alcohol abuse and risk of school failure. Think about where you would meet her, how you would ask her questions in this brief 20-minute visit, where her agenda may not match yours. What are you going to accomplish? How can you win her trust? A harm reduction approach works very well in meeting teens where they are, in meeting anyone actually where they are. You have to have a non-judgmental approach. You have to find some dignity and value in that person that you're interviewing, no matter how broke down they might be. Those are the simple requirements to interviewing someone respectfully. When they sense that you have respect and you're not judging them, they tend to open up and you might win their trust. In this case, I would work with this teen on her birth control choices and her sexual health. And I am concerned that she's vague regarding the age of her partner. Also, the fracture that she suffered at age 5 might be a sign of abuse in childhood. So putting that all together in a 20-minute visit, I would work quite hard with her on her choices for birth control and maybe screen her for whether or not she feels respected by her partner in her choices for sexual health, sexual activity, and her choices for birth control. Certainly, I would offer birth control to her, along with a harm reduction approach to minimizing risk for sexually transmitted infection in the future. Segueing from a birth control discussion to a conversation about whether her partner respects her birth control choices and respects her choices on sexual activity, how often, and whether her independence is respected is a nice way at getting at whether or not she is at risk for abuse.
All adolescent patients deserve compassionate and appropriate education, screening, and resources on issues relating to healthy and unhealthy relationships, and we'll discuss in the next training a universal approach to this. But we also see, as in Dr. Hartman's case study, how important it is to pick up on specific abuse-related risks an adolescent patient may have, and to provide responsive and compassionate care to reduce the potential harm. The ways that abuse may present in terms of symptoms and behaviors in an adolescent patient have much in common with what we see in adults as well.
Adults who are experiencing intimate partner violence or sexual violence can be affected in many ways. Increased risk of post-traumatic stress disorder, anxiety and panic attacks, insomnia, depression, alcohol and drug use. And we see, and this is something you may be seeing in your practice, that women who are experiencing domestic violence are 2.6 times more likely to use tranquilizers, sleeping pills, or sedatives, more likely to use alcohol and tobacco to help, again, as coping mechanisms to deal with that stress, or because it's part of the abuse. Women who have experienced domestic violence are 2.6 times more likely to be diagnosed with invasive cervical cancer. As we talked about before, abuse has effects on the immune system, also on exposure to sexually transmitted infections, and the ability to access care regularly, which means that problems may be found when they're further along. One thing we know, and this is really important, is that knowledge is not enough to prevent sexually transmitted infections and other problems. Knowledge is important, but as this study found, under high levels of fear of abuse, even women with high knowledge about STIs were still less likely to use condoms consistently than women who had less knowledge but were not afraid in their relationships. I bring this up because often when we talk about sexual behaviors and risky sexual behaviors, we talk about them as though they're always a choice that the patient is making. And it's important to remember that that patient may not be in a position where they're able to negotiate safer sex practices or even when they have sex, or who they have sex with, especially if they are being trafficked or in a commercial sexual exploitation position. Abuse puts people at risk for STIs, and STIs can put them at risk for more abuse. So as Judy Auerbach says, research shows us that violence is both a significant cause and a significant consequence of HIV infection among women. And other studies have shown that men who are HIV positive also report more abuse as a consequence of their HIV status. Intimate partner violence can also be a barrier to obtaining regular care for HIV and AIDS. It can also be a barrier to obtaining regular care for dental health. Women and children who experience DV are at greater risk for dental neglect, which can result in a number of different health complications. Domestic violence affects adults as it affects adolescents and children by increasing the likelihood of multiple comorbid health conditions, which you can read here. I want to talk about one very serious form of physical abuse with great medical implications, and that's strangulation.
It's really important to screen for and identify strangulation. Not only can strangulation have immediate effects, there can be delayed effects because of the swelling and edema that can present up to 48 hours after the event with life-threatening complications. That said, if you identify somebody who's been strangled, you have time to get them medical help that could save their life.
This is a very important topic to discuss, and part of that is because victims and sometimes service providers may not understand the gravity of that kind of behavior. One thing is that victims may refer to it as choking rather than strangulation, and as medical providers, we know that there is a difference, but that's one of the words that's used instead of strangulation, and so can sometimes be used as a way to minimize the abuse. Another point of that is that it also indicates a very high lethality in that relationship. Victims of prior non-fatal strangulation are 7 times or 800% more likely of becoming a homicide victim. And in some homicide cases, the first physical violence in the relationship is the homicide itself. And so whether it's the indicator before the homicide or the homicide itself, it's important to take strangulation very seriously.
Encountering victims of strangulation brings into clear focus the fact that domestic violence not only threatens the health of victims and their children, but also their lives. It makes clear that if we don't prioritize preventing and intervening in violence, we will continue to lose lives. As Alaskans, we are tragically far too familiar with the headlines about mothers being killed in front of their children, of whole families being killed in murder-suicides. There have been many of these in the past few years alone. In fact,
not only is domestic violence implicated in a whole range of health conditions, but it was also related in 62.5% of homicides against women in Alaska. Numerous studies have shown that women experiencing domestic violence have higher overall healthcare costs, and that women and children exposed to domestic violence have higher utilization of physical and mental health services and of the emergency department, have more missed appointments, have fewer on-time vaccinations, and well-child visits. Domestic violence has profound effects on health and on the functioning and financial viability of healthcare systems. The way that the physical effects of domestic violence show up in your clinic may range from headaches, chronic pain, to difficulty managing chronic diseases, STIs, etc., to much more severe physical effects of of multiple forms of trauma in a patient's life.
Now Dr. Dan Hartman will present the second case study, this time a young adult patient.
Your next patient is a 19-year-old that you're seeing in clinic after follow-up from admission. She was admitted for alcoholic cardiomyopathy and heart failure. She is HIV positive. She is someone who's alcohol dependent and polysubstance dependent. And she's been marginally housed and homeless and engaged in sex work. She comes to your clinic clinically well and compensated after this admission. She has an established diagnosis of alcoholic cardiomyopathy, as we mentioned. Her ejection fraction is only 10 to 20%, so she is very severely ill at the age of 19 to have such significant heart failure. She socially bonds with an 18-year-old member of her original community who is also engaged in sex work and is also HIV positive, but otherwise she's very socially isolated and she's estranged from her family. Chart review shows a history of sexual assaults beginning at age 5 and 6, and the perpetrators were prosecuted. She was later raised in a series of foster homes. So think about some of the questions you would ask. Think about the approach or the footing that you would take with this person. How would you meet her to help her? What are her needs? If you're successful in a harm reduction approach, you'll win someone's trust and they'll come back. In this particular case, we did win this person's trust and she did come back, and we learned a lot more about her and she was quite open with us. She was very pre-contemplative about changing her life, very much engaged in a life of daily sex work, and there was a real question as to whether this was coerced. It wasn't necessarily her choice. She had begun this life in mid-adolescence when she was still a minor. Child Protective Services referrals and Adult Protective Service referrals were carried out by other providers, and the state was definitely involved in her care, as were a number of private and voluntary organizations. This was a difficult case. It's hard to treat somebody when the choices that they're making are so destructive and difficult. But it's important to remember that no matter what choices people make, they deserve the most compassionate care, and we do need to give them the most compassionate care possible. So using a harm reduction approach, using motivational interviewing, these are all the tools in the box, but at the heart of it, you need to find dignity in that person. You need to find some value in that person, otherwise it's going to be very difficult for you to win their trust.
As Dr. Hartman explained, we can't do everything for patients, and we certainly can't expect to be superheroes, but we can offer compassionate, evidence-based, culturally appropriate care. And patients want that. Patients in multiple studies have said that healthcare providers are people who are appropriate to speak with them about this subject, and that they want to be taught, they want to be educated, and they want to be asked. I'll share with you this quote from a novel about a domestic violence victim. What you do in your practice can make a big difference for people. And so for the next 2 trainings, we'll be talking about how to do that. First, focusing on how to create a safe environment and do integrated education and assessment for patients. And in the 3rd training, we'll be talking about how to respond to a disclosure